Hello, everybody. Good afternoon. I know most of you, so I'm just going to do the introductions, and then I have a colleague here who will introduce me. So it's a little bit of a strange structure, but so introductions. So please join us next week on the 10th for the next lecture series. Installment, The Hidden Diversity of Japanese People, Deconstructing Japan's Nation-Building Process, Professor Masataka Okimoto. And that will be in room 110, not this room. For you who are attending by webinar, there's their microphone. So I'm speaking to them. If you're attending by the webinar, webcams and microphones are muted. So please use the Q&A function during the lecture to submit your questions, and I'll try and answer them if I can. A live transcription feature, closed captions, is enabled, but if you don't want to have it on, you'll need to click on your closed captions button to turn it off. This will be recorded also, and I believe it's going to be put on YouTube. Finally, please check the CJS events page for various social media posts that we do and other events.
Okay, yes, good afternoon, everyone. Okay. Yes, okay. Good afternoon, everyone. Thank you so much for coming to today's, the CJS lecture event. So I'm Sachiko Kita, a visiting scholar at the CJS since this September, and I'm a moderator today. So, today's presenter is the Professor Denise Saint Arnault. As you know, she is the director of the CJS. Okay, so I'd like to introduce her to everybody. Professor Denise Saint Arnault is the professor of nursing here at the University of Michigan. She worked for the 20 years in the clinical practice as a psychiatric nurse treating depression. In her research, she has developed and tested a theory on the culture, distress, and help seeking. So she used a mixed method to understand the internal variables that influence the symptoms experience, including the belief about the cause, social network relation of health seeking, and meaning on the recovery and health. Healing. And her research includes the federally funded studies that examine the personal, cultural, and social influence on illness experiences and help seeking for the mental health distress and trauma. Then her qualitative work includes ethnographically informed methods, such as the photo-elicitation, pulse source, the lifeline, body map, fieldwork, the grounded theory, and clinical ethnography. Then she's my mentor, and she's a remarkable and leading scholar in the trauma recovery research in the world. So everyone, please join me in the welcoming Professor Saint Arnault.
When I wrote this lecture, I had no idea how to begin because really my work with the Japanese population has started in 1993. So I've had numerous studies since then. Some of my work has transformed in the last 10 years, as Sachiko said. So we're doing more trauma recovery, and it's a more global project. So what I decided to do is sort of kind of a retrospective-y kind of why would a psych nurse be interested in culture? How does clinical ethnography inform clinical practice? There's issues of translation involved. There's issues of assessment involved. So I thought I'd sort of give you a view into my life as an ethnographer and a nurse. So I thought you'd enjoy that. I'm hoping there's a few students online because some of the implications for translation and instrumentation in research are apparent here. So those of you who are teaching language, take this back to them if you want to need some articles or something, because it's huge, actually. It's so huge and so underdeveloped in nursing. So we'll start with it. So Mrs. Koga was a company wife. She was with the Mazda, I believe, and she was a Japanese woman living in the Detroit area. She brought her newborn baby to the side of a pond. And when she sort of came back to herself, the baby was dead. She had drowned her baby. And this began a flurry of, what do I want to say, demands from both the Japanese side and from the American side. Oh my God, who are these Japanese people living in our community? What do they need? What's going on here? I don't understand. And from the Japanese side, oh my God, how did this happen? We thought we were supporting her. We did everything we could for her. So this is from our dearly departed Mike Betters. This was written in 1997. This occurred in 1995. And at that time, I was a psychiatric nurse. I was in clinical practice, and I was also an educator and teaching students on the psych units. I was a third-year anthro student at Wayne State University in medical anthropology, and I was also a second-year Japanese student. And my tutor came to me and said, Denise, you're a psychiatric nurse. Let's do something. So that began a sort of a long journey of creating lectures. We did a series of newspaper articles. I did a bunch of informal interviews with the Japanese Business Society of Detroit Women's Club and a bunch of other clubs, various maternity groups. I spent a lot of time at the Japanese Saturday School, which has been relocated now. It's up sort of near Novi. And we did hotlines and focus groups, and I translated a bunch of materials so that people could, access the healthcare system in some sort of a strategic way. So that was sort of psych nursing, or really more of a culture broker is what I was trying to do. I was trying to sort of assist the population, but I wasn't at that time researching the population. And people kept saying to me, oh, Denise, you're a psych nurse. This was postpartum depression. You should study postpartum depression. But I was an anthropologist, and I knew that there was a lot more going on here that we didn't know. Also, I was the psych nurse for Mrs. Koga when she was at University of Michigan Hospital. It was only about 6 weeks that I provided care for her. And the other thing I noticed is I want to say abysmal, how abysmal the staff were in trying to understand her, trying to understand culture at all, trying to understand this person, trying to understand what she was going through, what was happening for her. For example, she had a shrine in her room, and she was, she had her salt, and she had her water, and she had her, and she, it was for her baby. She was talking to the soul of her baby. So they said she was delusional in the medical records, the psychiatrist. So I'm, flipping out, but I'm just a nurse in the psych hospital. And what am I going to do? So I tried to initiate some grand rounds and understand, and sort of that every time I would see something with her, working with her, I would run to the literature and try and figure out, what am I seeing? We had no idea what we were seeing. So I was more fascinated with illness expression and help seeking and what failed in the community. The newspapers were saying, oh, her social support network is really strong. Well, if it's that strong, somebody should have seen, because she was very evidently depressed. She couldn't bathe, she couldn't communicate, she could hardly move. She was practically catatonic. So if the community was so engaged, how could they have? And then what about the medical community? Her doctors, her nurses, right? So I was really interested in this huge picture. So I'm going to take in a little interlude and talk about why distress is cultural. And then I'm going to go into a series of studies that I've done that just to give you a glimpse of how from a psych nurse anthropologist side, how would we approach such a big thorny issue? So this is a model that I recently published. One of the things that bothers me a lot in my field is they talk about culture as beliefs and values, or they say it's just a societal thing and we can't understand it. We just do it. We can't really break it down. What I believe is we absolutely can break it down, and that culture has numerous levels. The one thing I want to note here is that, of course, culture is implicit. It's tacit, it's procedural. You do culture. You live culture, and it is difficult to explain. That particular issue in culture and well-being and health and illness expression really preoccupies me because it informs everything that we do when we try and study it. People can't tell you, okay, I'm your nurse. Tell me, how are your thoughts and behaviors, how are they informed by your culture? You can't answer that question. That's what the interviews look like still in our field. So I was really preoccupied by that. We had no way of understanding it, assessing it, learning about it. So I'm going to talk about each of these pieces, but there's sort of this universal component that is culture at the sort of societal level. And then there's, of course, the intrapersonal level. And I'm going to talk about all of those. So the universal level is the beliefs and values of a culture. But the beliefs and values of a culture are at the universal level are really about what's moral, what's good, what's right, what we should be, how we should be. So these are broad philosophical ideals about how a person should be in the world. And the other thing that culture has is behavioral prescriptions. That's the rules and the regulations about how you're supposed to be. So what happens when you violate these codes of conduct? How are you warmly welcomed back into the community or ostracized by that community? And what are the rules and regulations specifically? And what are those violations? So that gets into things like stigma, ostracism, the ways that communities can shun people. So when you study depression in the Japanese community, that's actually figures pretty huge. It's almost the centerpiece to everything else that I would learn. And then there's the social level. So the social level would be a little smaller. It's not philosophical so much as it is maybe sort of local groups, like your bigger regional community. You're from Tokyo, you're from the Kansai region. It would be sort of that big, but not all the way down to your family. And these are the motivations, goals, social roles, preferred patterns of behavior. And it also includes conceptualizations of the body. Who am I in here? How am I supposed to look? How am I supposed to act? How am I supposed to move? Doing all my field work in Japan, of course, I move freely as an American. I don't have to worry so much about taking space. In Japan, of course, you know that you do worry about taking space. So usually within a week, I've got neck pain, I've got shoulder pain, because you're sitting like this. To me, it feels like I'm sitting like this. So it's conceptualizations of the body, it's how you move in the world, and beliefs about what makes a healthy person. And the other thing that's at the social level, this would inform things like hospitals, medical systems, treatment plans, care providers, would be things like what illnesses how do we name them? How are they dangerous? How can they be treated? How long do they last? That kind of thing. Then at the interpersonal level, it's how do I do it on a day-to-day basis? How do I speak? How do I dress? What kind of social distance, food choices, and also for me, emotional displays. So I'm really interested in how do people show how they feel in a social context, especially if they're distressed. What do you do to show somebody that you're distressed? And what's your expectations that they would respond, or how would they respond? And then there's the culture inside of me. That's all the things that nobody ever sees. Those are my private moments when I'm laying in bed at night. What do I worry about? What do I feel inside of myself? Those are the sensations that I experience. So one of the things that we've worked, all of us in our research teams, and for me during my career, is trying to get away from words like symptoms or symptomology. It's not about symptoms. It's about sensation. What do I feel? And then there's a whole bunch of things that happen once I feel that. I've got to name it. I've got to enact it. I've got to ask for help from it. There's so many things that go into that sensation. And the other thing I believe, this is me now conversing with transcultural psychiatry. One of the things I believe is that sensations are normal within their cultural context. So to take swaths of society who experience sensations as physical, or they experience distress as physical, and say that that is somehow pathological or somatization or immature psychological development, makes me just want to scream. It's outrageous. And 2/3 of the world, maybe 3/4 of the world do that, right? They experience distress. They experience it physically. They express it physically. And we're in psychiatry saying, oh, that's emotionally immature. That's somehow poorly developed selfhood. It's not right. So that's one of my big preoccupations, is to fight with psychiatry and psychiatry's models. So what I believe is that as the minute you're born, your culture tells you what you should pay attention to, what that means, what it should feel like. So maybe a Japanese baby is asked, what's your stomach? Show me your tongue. What did you eat today? Let me see your poop. Right? So there's a completely natural preoccupation with the body in that culture. In an American society, oh, honey, how are you? Oh, your stomach hurts. You must be anxious. Right? It's instant. It's completely normal to emotionalize every physical distress signal from an American child. So what? So how am I going to study this Japanese distress? So I got Mrs. Koga on my mind. I've got this abysmal clinical situation that I know is happening everywhere for every woman of the 10,000 women who are, 10,000 people who are living here. So I'm trying to develop, flashback to 1995, 1996. What am I going to do? How am I going to study this? And how am I going to wrap my arms around the breadth of it, the complexity of it, and make it somehow meaningful to practitioners on the other side, something I can explain to them, something that would change their practice in some way. So what I'm going to do today is sort of break it into two parts. The first part will be the quantitative journey. So one of the things that's really important in medicine, nursing, the health field, is measurement. And we're really preoccupied by how did you measure it? What instruments did you use? How do you know that that's true? How many people have it? I want to see a really big sample size. So that's the audience I'm trying to talk to. And it's what, 1996, 1997. So I'm trying to figure out, how am I going to do this, right? All right, so just a second. All right, so in that era, so in the 90s, early 90s, mid 90s, and early 2000s, there was a huge anthropology literature using ethnographic methods to explain cultural variations in distress. But they were very almost anecdotal, not anecdotal, sort of anecdotal. They were sort of written for an audience to sort of read as an ethnographic exemplar. They were not convincing to most practitioners. Most practitioners never read any of those. But it was a big body of literature. I mean, stacks and stacks. It was super fun for us to read. But I knew that practitioners were not looking at this. And then there was this transcultural psychiatry program that was beginning to develop. And what they were doing is they were saying, we need to ask the psychiatric questions. Are you depressed? Do you have crying spells? How often do you have crying spells? But we have to contextualize it. So if they have lots of crying spells, somehow we're supposed to talk about how that's relevant to Japanese culture in some way. It's really questionable how much that has changed the field. Their cultural formulations is in all of the diagnostic manuals. Most people I talk to don't even know they exist. So nobody's using these. My preoccupation, because I'm now back to me, I'm a psychotherapist. What do I want to do? I want to help the participant explain how they're feeling. So that's like a whole different thing. I got these audience over here that I want to influence, but I've got this poor suffering woman in front of me trying to explain what it's like for her. So I've got these two sort of bookends of how am I going to do this? And I wanted the women to be able to explain how they feel their suffering, tell me what that suffering means to them, and decide what to do about it. The other thing that was really big in this decision-making period for me was I knew that practitioners wouldn't do this for hours. They weren't going to do field work. They weren't going to go learn the culture. They would give an interview. They would give a 1 hour interview or a 1.5 hour interview. So I was trying to think of a way to do a 1 or 1.5 hour interview and that could be used in clinical practice. So as a psychotherapist, I wanted to make a difference. I wanted to actually help the people. That's my overriding goal still to this day. All of you know, that's the point of all of it, is that we're going to make a difference. As a theorist, I was trying to cast the net really wide because I knew it had beliefs, values, social implications, social systems, internal sensations, meaning all of that I talked about. As a practitioner, I wanted a way to discover distress that could be used easily in clinical practice and didn't require complex clinical training. And then as an anthropologist, I was looking at this implicit piece. I knew that people couldn't just tell me about your culture. You can't explain it. You can explain it over time, over weeks, if I hang out with you long enough, but you can't just explain it to me. So I was really trying to get at the how of it, the why of it, the so what of it from a person's point of view. And then I'm a humanist. So I wanted people to walk away better than when I met them. I wanted them to be happier, healthier, more able in some way because of the research participation. So I'm going to talk a little bit about quantitative measures. This is really fun and a little bit obscure. So many of you are in the humanities, so this might seem a little foreign to you. So please raise your hand and stop me if you don't understand what I'm saying. And of course, I'm moving at a brisk pace because I want to get to some of the good stuff, which is the qualitative stuff, which I really enjoy. But I want to talk about quantitative because it's so central in medicine, nursing, health sciences. The instruments we give to the patients, that's what I want to talk about right now. So the first question that came up for me really, really early as I started looking at Japanese depression is, what are we going to call this? What are we even talking about? So I could use the word utsubyo. I could talk about depression. Or I could broaden the concept, since we didn't know exactly what depression was. I broadened the concept, and the community was really responsive to the use of the word hutsu, which would be more distress in general, suffering in some form. And the other thing I noticed really early was that people were using seishinryo as the primary concept for depression or mental illness that implies schizophrenia or dementia. So we had to get rid of seishinryo really early. This was probably still I was just launching my program of research at this time. So the community, we did a bunch of sort of focus groups and meeting with the company wives, and they talked more about kokoro no byoki, this sort of sense of I'm sick in my body, or I'm pointing here because it implies heart sick, or but it translates to my body is sick. But it's not, or my heart is sick, but it's not your heart. It's not your heart, and it's not your heart the way that we mean it in America. Because if you were to point to the heart or the soul for the Japanese, it would be here anyway. So it's a weird translation, but it was really useful. So one of the first things we had to do was figure out how to translate the instruments, because they were all using words that were inappropriate for this line of research. So one of the things I had to do was find ways to talk about emotions and feelings, these sensations that I was referring to. There were at least 20 emotions checklists. This was sort of during my postdoc, and a little bit later, I was working with emotions checklists. I did a bunch of studies on comparative emotions. Dr. Kitayama is here. And Dr. Hazel Marcus was here. He helped me work with Japanese emotions of distress. There was a few articles, but of course, a lot of people would sit down with me and say, well, what about this one? What about this one? So we pulled together lists of Japanese emotions. I'm calling them emotions because they're kind of social. They're not exactly emotions. They're sort of social, emotional, physically kind of, it's not emotion the way that we mean it in America. And I also had to spend a lot of time with sort of really old Japanese studies of what constitutes distress, how do we understand distress philosophically. There was quite a bit of Japanese medical research and Chinese medicine research about distress and psychopathology. Of course, Dr. Doi was instrumental, but he was not the only person. There was several. And then the MedAnthro material. So in the end, I realized we knew very little about Japanese distress. So to start it out, in one of my big studies, I created a symptom inventory. This was a composite symptom inventory. This is just what it looked like. There are 120 symptoms. So when a person received their survey in the mail, they would have a page of symptoms, and they would endorse those that concerned them or preoccupied them in some way. And these were side by side with more standardized psychiatric instruments like depression inventories, anxiety inventories. And in that study, what we did was we did ethnographic interviewing, which I'll talk about in a minute, this very sort of extensive survey. And then we also did, after that interview, in 2 weeks, we did a psychiatric eval. So we all had to learn psychiatric evaluation, and we had to go back out to the woman's home and do the checklist. Do you have depression? Do you have sadness? Do you have crying spells? And so we were doing a sort of side by side with ethnography and psychiatry. So this is just a couple of the studies that I thought you'd enjoy looking at. One of them was the symptom profile for the Japanese women. So I replicated this in several communities of Japanese women, the ones in America, some student groups, and then a series of studies later in Otsu City. But anyway, so depressed Japanese women had 26 symptoms. And here's the sort of breakdown of what these symptoms are. Of course, there were GI distress. That was pretty primary. Abdominal cramps, indigestion, no appetite. And then there was the sort of neuromuscular, which would be weakness, lightheadedness, feeling faint, feeling numb in the hands was actually surprisingly common. I spoke to people who had numbness on one side of the body, headache, fatigue, and tiredness I expected to see. And then GI, I'm sorry, and then sort of muscle and joint pain in the shoulders, cold hands and feet, and chills. I expected to see that because it was written about in the literature. The American women didn't have these symptoms at all, but they did have joint pain. So we see this a lot in clinical practice with Americans. Pain when people are depressed is quite common. So one of the things that I also hated in the literature at the time and still do is the American-Japanese comparison. It's pretty easy to find differences between Americans and Japanese. So I took on the issue of what is this thing called Asian? National Institute of Health was doing this big Asian research thing. I went to a bunch of summits and they were talking about Asians as if they were a monolithic group. Obviously, they're not. That's, anybody who knows anything about people with Asian descent or East Asian descent would know this. So then I did a fun study of Japanese and Koreans. So instead of comparing apples and oranges, I'm comparing little oranges with bigger oranges or something like that. So the ones that are in the dark are the ones that you're shared. This is not rendering very well, but the ones that are in the dark are shared. I'm sorry, it's sort of rendering, you can't really see. Maybe you can see better than me. Only 11 of the 26 symptoms were shared between the Japanese and Koreans. So you see stark differences actually in Japanese and Korean distress or depression symptoms. So that was one of my funnest articles. Really enjoyed writing it. And it got published immediately. It was so cool. How often does that happen? You send it into the journal and I got a letter in 2 weeks saying, we love this. Thank you very much. It's published. So that was a gold star for me. I really liked that. All right. One of the things that I'm going to say something about this before I show it to you. One of the things that we did when we were translating, so translation is huge. We had a team of translators, and we had translators from 3 different regions in Japan and a sort of very different disciplinary backgrounds. And we translated instruments for months, 6, 8 months. We translated, and we'd back translate, and we'd share our translations, and we'd process the translations. And it was super fun. By the way, it was one of my funnest times in research. That was so great. And I always love comparative translation. Sit down with a group of people and what is the word for lightheaded in your culture? It's so fun. But what we didn't translate was the depression instrument. And the reason we didn't translate yes.
What's an instrument?
Instrument, a survey, like a survey, the 12 questions or 20 questions. Thank you. The survey instrument. So we took the depression instrument that had been used for 25 years by the Japanese Institute for Mental Health, which is their National Institute of Mental Health in Japan. They had translated it and they had been using it for 20 or 25 years. So we thought, well, this one's golden. Don't need to translate this. So we didn't even look at it, actually. Oh my God. So we're halfway through the surveys. We're starting to look at the surveys, and the stats people are saying, oh, Denise, there's problems with these 6 items. And I'm like, what do you mean problems with 6 items? I don't understand these words. So these were not translated correctly. So the 25 years of Japanese research was assessing something that, in my opinion, is not depression. They were assessing other things. Not that they weren't related to depression, but it wasn't the same. So these are the 6 items that we found: the English, CESD, the original translations, the back translation. When we back translated, once we realized there was problems with the instrument, we back translated it, and then we revised it. So this took many months because we had to sort of figure out the idioms of just depression for the Japanese population. In some cases, we were looking at philosophical materials. Yes. CESD is the tool, the instrument, and it's a composite. What does CESD even mean? We always just call it CESD because we've been using it since 1975. Composite something symptoms of depression. It was developed at National Institute of Health in 1975, and it was translated by Shima's group in 80 something. I'd have to get the reference, 80 something. So interesting. Very sort of specific to Japanese culture, but for me, this just shows how poorly we are doing in understanding people's experiences of distress or depression, paying attention to how those things are translated, paying attention to how our interviews are instruments are given to our population. And this, I could go on for days on this. This was with every single instrument. But that's why we spent 8 months on the front end. So we found all that. We just didn't realize it was also in this widely used standardized survey tool. Some of these back translations are not wrong. Depressed people do experience pessimism, for example, but it's not the same as hopelessness. And hopelessness in the Japanese context is completely different from hopelessness in American context. Hopelessness in America is, I don't think I can do it. Hopelessness in a Japanese context is, I don't know if my community can support me. I'm not sure there's a path forward in this world, in my society for me. It's completely different. So to make that kind of translation error to me is unconscionable. But nobody reads this article, unfortunately. It's really obscure and it's in a Canadian journal. It was super hard to get published. Okay, this one is super fun. So it's not like we didn't know that Japanese people had physical distress. We knew this. We knew that Japanese medicine was sort of preoccupied with Japanese physical expressions of distress. There were several books written on this. Fute Shuso is a concept that was kind of widely written about. There was actually several magazine articles about it. So we knew that Japanese people and Japanese women specifically had physical distress. That wasn't sort of a surprise. My enterprise was trying to figure out how to document it, how to make that kind of information available to providers. This article, Rei Sakakibara, some of you know, and I were very preoccupied with some of the data we were getting. So she was a really fun person to work with, and she was a nerd like me, so we did the hard work to see if we could document this Fute Shuso, and also to see whether or not Americans had it. Because people say, oh yeah, the Japanese have it, but do the Americans have it? Maybe it's just a depression view. Fute Shuso, I can't go into all the details, but you know that list of the 26, many of those are that. It's dizziness, lightheadedness, a sort of a feeling faint, feeling very weak. You can't move, you're flaccid almost. It's sort of this, you know, it looks like depression for sure, but it feels very physical. So this is a fun study. I can't get this one published. I'm going to send it to a Japanese journal, I think, to see if they might. So in the Americans, we did see something, numbness, chest pain, palpitations, and ears ringing. And then we also found what's very common in depression when you meet with American depressed people, that they're annoyed and they've got a lot of pain. You see that also in Japanese, this sort of annoyed, angry depression. Angry depression, very common in Japan. Any of you have ever seen a person in Japan who's depressed? Really what you walk away with is that person's mad, really mad, very annoyed. But we were able to demonstrate fute shuso in a way that's different for Japanese in here. So that was really fun. And thankfully I had taken the time to do those instruments in the beginning so that we can send this back. So in America, it's somatic depression. So you do see headache and distress. And the Americans did actually have cold hands and feet, which surprised me, because that's sort of a classic Japanese expression.
Denise,
Yes.
question. Can we go back to that?
Yes.
What is ANSD like?
ANSD is the fute shuso literature. First, it was considered to be a Japanese specific illness expression. Then a lot of psychiatrists said, no, this is actually autonomic nervous system disorder. And so they started a big line of research. Japanese and American psychiatrists actually did a really big series of studies to see if we could document autonomic nervous system. And that's really important clinically because you can treat autonomic nervous system disorder. So if it is autonomic nervous system disorder that the Japanese are experiencing, there's actually something you can do for that. Where if it's somatic expression of distress, it's all psychological, it's all in her head, just send her to a social worker, she'll be fine, what can we do? So it really matters. And we do see it in a subgroup, but it's super fun. That's another really obscure article. So this is my heart. This is the qualitative interviewing. So remember back before I said my goal was to help people explain their distress, to find a culturally neutral way to help people explain what it's like to feel as they feel and to try and get help in that situation. So my colleagues here have used this instrument a lot. It's super fun to use, easy to use, an hour and a half. So I just want to show you this instrument. So we didn't want to label people. The psychiatric labels and the psychiatric interviewing I thought were inappropriate. And they were asking people, as I said, tell me how your culture experiences affect your depression expression, right? How you can't answer that question. They were using Western derived measures. So they were center staging emotion over physical experiences. And they were hours-long interviews. Many of these interviews are 4, 5, 6 hours long. Wow. So that's what I was trying to work against. So I worked together with my colleagues to develop an instrument that was structured, helps people describe their distress, culturally neutral, trauma-informed. I've always been concerned, especially working with the Japanese. Many of the participants, if not most of the participants, had been bullied. Many had been abused as children. Almost all of them had had sexual experiences in their marriages that I might call rape, but they didn't exactly. It's a very traumatized population. So I knew it had to be trauma-informed and it had to be short and easy to use. So the first thing you do in this interview is I ask the person, please show me your social world. So these are some renderings from a participant. These are all from the Japanese immigrant group or the Japanese sojourner group. So this particular person has lots and lots and lots of groups, but she's not exactly connected. The groups kind of encircle her, but she's not really connected to them. This person's very connected with some of them. She's got American friends. She's got her dogs on there. A lot of people put their dogs on there. Some people put God on it. They'll circle the whole thing with God in terms of their social world. So that's the self out there. That's me in my social world. So that's the first question in the interview. The second question in the interview is, what is it like to be in your body? What is it like to be inside your body? So we call that a body map. And this person writes about physical pains that I expect to see. I see them on almost all of them. We're spending a lot of time on these body maps right now. We've got a really big international project trying to understand the body and distress and recovery. This is another one, no words, but she describes that is power coming out of her hands. She was sexually assaulted and has menstrual pain and pain on intercourse. She shows her heart, but she depicts her heart as a heart, an actual physical heart, because she has pains in her heart. She's confused all the time. She puts eyes on. Many of the Japanese put eyes on. So that's the only culture that does it. Now we've got 13 cultures and nobody else hardly puts eyes on. The Japanese always put eyes on. It's kind of cool. Back pain, weight gain. So that was me out here, me inside here. And then the next question is, tell me about your life. So we use a lifeline. So she's here. Anyway, so this is a lifeline of childhood. Very many of these had bullying in childhood. Almost all of them actually had bullying in childhood and very sort of controlling mother, absent father kind of a profile. This is a different one. Again, you see the sort of bullying and the pain of the experiences of childhood. Childhood's not sort of a happy time in most of the Japanese. So that's me across time. And the last question is, pick a low point. Pick any low point, or in my research, we use the most recent low point. I think in this case, we use this one. Most recent low point. And then we ask them to describe that low point using cards. So we have 45 cards. Well, we had 36. We added some positive cards. So this is the person explaining their distress using the cards. It was using these cards where me and Ray sort of saw the fute shuso symptom expression. So I was really glad we added this piece because we wouldn't have seen a lot of this stuff if we had just asked for the check boxes and stuff. So in these cards, what people are doing is sort of mapping their distress. What does it feel like? Yes. But what does it mean? What does this set of feelings mean? What does this set of feelings mean? And then what does it all mean to me, in my life, who I want to be, how I want to live my life? This person was sexually harassed. So that's the interview. It takes about 90 minutes to do. I personally have conducted, I don't know, 150 maybe. We have a research team now among us all. We're probably into 250 or 300 interviews now across several countries. But this has been extremely useful because it is culturally neutral. It allows anybody to explain their distress in any way that they want. It's super fun. And when they get done with this, they're like, wow, that is so interesting. I had no idea. I had no idea. You know, you don't look at yourself that way. So it achieved our goal of, helping the people feel better when they left as a result of participating. So in the next couple minutes, I just want to show you some of the work that resulted from the interview data. So this is, so what we do often in nursing, in psychiatry, in psychology is we create theory. So many of us are creating grounded theory. What grounded theory is you listen to your constituents, your participants, and you try to model what are they saying? How does this phenomena go to this phenomena, go to this phenomena, or this outcome? And once you have that mapped out, you can actually predict behavior and you can give interventions. for to promote health in some way. And that's the goal of, nursing and healthcare. So I'm not going to go into this. I don't know that this is the best grounded theory, but it was a student. This is Courtney's work. So she was a hard worker, and it's okay. It's really interesting, but this is a grounded theory. So she used the qualitative data to come up with this theory. I'm not going to go into the detail. This is another theory. This is Shizuka Sakakibata, one of my research team. We kept hearing from the women, it's not the distress. It's not the 26 symptoms. It's not the 75 symptoms that you're seeing. That's not it, research team. What we're trying to tell you is we all have lots of pain. As Japanese women, there's a huge amount of suffering. There's a lot of physical pain, a lot of stress. And what the community was telling us is it's not about the pain. It's about, oops, sorry, what do I do now? Help me quickly. It's about the ikigai. It's about what does it mean to me? What does it mean to me in my purpose in life? So if I'm suffering and I'm achieving the goals for myself and my family, it's okay. It hurts, but it's okay because we're all good. We're all doing well. This ikigai balance and this ideas of quality of life and the importance of suffering and the meanings of suffering. That's all right. There's 2 more. Just 2 way to the bottom. I'm sorry. I started clicking and I hit the wrong button. That one, 37. Thank you. All right. So it's about ikigai and it's about balance. It's about meaning in life. It's about your life goals. And this is sort of, we know this. I think everybody kind of knows this. And we all knew about meaning in life, but surprisingly, I was not measuring meaning in life. Even though I was really interested in it, I didn't even think to measure it. And it was through this research that meaning in life and assessing meaning in life has become sort of my primary preoccupation right now. And it turns out that even in the trauma recovery group, meaning in life is the overriding variable. If I had to pick one thing that shapes recovery, it's this meaning. If you have meaning in life, you can take it. You can get through it. You can do well despite, pick a thing. So I won't go into the details, but that was really important knowing for us based on the qualitative data. This is an iteration of one of my earlier theories. This theory has sort of got legs now, and we're doing lots of work with it. This was a really early version that, people suffer, and then the suffering has these sort of components, which I've described to you. And then in the end, you decide, do I need help or not? Based on some things, and then you do get help. So that was the early theory. There were no help-seeking theories at the time. There's very few still. This is the current theory that we're working with. This is the cultural determinants of trauma, help-seeking and healing. So this is the one that we're kind of working with now. So we're doing a bunch of testing. Sachiko's really great with structural equation modeling. We're testing various variables in interviews across several countries. It's essentially the same, but we're interested in barriers to help-seeking distress experiences, which the sense coherence is a meaning in life variable that's really important. And then the healing outcome that Laura developed. So we're so happy to have that. So I believe that's it all in an hour. I can't even believe it. Yes, it is.
Yes, thank you very much, Denise, for your wonderful presentation, and it's insightful and inspiring
Thank you.
presentation. Okay, so we have 30 minutes for the Q&A session. So if you have any question, please raise your hand. That on-site participant and online participants, please write your comment or question in the chat box. Okay. So, how about first question from on-site participants?
Yes. Oh, you're running it. You run the Q&A. I'm just gonna be here.
Yes, please.
Thanks so much. It was really great to see an overview of your work over the years and some of the issues you deal with. I'm wondering, I think it makes a lot of sense to focus on women in this case, but I'm wondering how cultural constructions of gender shape how you interpret these results and how you help people in different contexts.
So do you mean my social construction of
I
my
think
own
it-
gender or gender in general?
patients
In the
themselves.
patients, got it.
So the kind of way they understand gender and how that affects the sort of cross-cultural translation and understanding of their own experience that might
Such a
inform you.
great question. So it's impossible to look at culture without looking at gender, in my opinion. I believe that culture is filtered through a gendered lens. So when people are experiencing all those aspects of culture that I talked about, the rules, the prescriptions, the expectations, the self-expectations, the feelings inside their body, all of that is also gendered. So there's different expectations for a boy and a girl. You go to Japanese family and the little boy is running like a hellion through the living room, and the little girl is very contrite and she needs to be busy and she needs to be working. Right. So there's everything is gendered actually. So, but it's always implicit. So the participant can't necessarily say to you, well, that's because I'm female, or that's because of how people see me as female in my society would be the better way to say it. Actually, in the end of our interviews, they often are reflecting exactly on that this is about being a female in this world. It's about expectations that I put on myself, how I enact them. One of the concepts we came up with in terms of trauma recovery, for example, is normalization of gender-based violence. So violence against women is normalized in all these countries. So most of the women talk about, yeah, well, I felt that and I didn't tell anybody, but of course I didn't tell anybody. No woman would tell anybody because it's normal. So it's almost impossible not. I've got a few people now who are starting to foray into working with men and looking at how gendered notions of masculinity or play in that. Most of our work now is gender-based violence. So many of the people are either trans men or gay men, or the very small group of people who want to talk to male survivors. The male survivors don't want to talk. But that's a totally gendered experience of the abuse in the first place, and then what are you going to do about it? So who was it? Just recently I was talking with somebody, and she's doing a work online, and there's a group of men talking about the abuse they had as children, especially sexual abuse, and she's studying how they express it in a sort of a data mining. I think it's called data mining in Facebook or something. Really great work. Thank you for that question.
I have two questions, if that's all right, somewhat related. It's talking about the reluctance to speak. Oh, thank you for your comment. First, the reluctance to speak. Did you notice? I'm thinking about your comparison between Japanese community and Korean community, a cultural difference in willingness to share either mental or physical symptoms. That come up. And also, is there overlap in your work with disability studies in any way? And how they perceive what's going on with them as a disability and ways to seek care or anything?
That's great. So the question for the audience is, first of all, did I detect any differences between Japanese and Koreans in terms of illness expression or distress? And then finally, is there any overlap with disability studies? So the first thing first, In Japanese and Koreans, there is kind of an Asian thing. You know, I hate to say it, but there's definitely an East Asian prohibition to expressing distress. However, it's expressing emotional distress, actually, not expressing distress. You can just express distress. But if you express it physically, it's going to be received in sort of a warm way. And if you express it sort of this emotional, I'm angry, or I'm frustrated, or I'm sick to death of the way I'm being treated, that's you will be shunned. The other thing I notice is the way that the cultural difference between, so the Koreans have a sort of a warm we-ness that the Japanese don't really have quite as much. So there's something a little bit more gentle in the Koreans that I have seen. But the Japanese healthcare system allows a lot of respite. You can take weeks off, and that's just fine because you're sick. And you can take weeks and weeks away because you're sick, as long as you're sick, as long as you're physically sick. So there is definitely something there in terms of conceptions of we-ness in Korean culture. It's not my area though, so I would have to study more. Disability studies. One of the things that I'm looking at Laura because she's doing a study right now, and you are not using the SENI though, you're using photo-elicitation, isn't that right? But we believe that these open methods are extremely valuable in disability studies because it allows people to talk about stigma, to talk about expectations, to talk about their personal view and the meaning of their suffering in ways that they really can't do in a lot of these surveys. So we believe that application of these methods in disability studies is really needed.
Right, so that there is one question from online participants. That is a very deep question.
Oh,
Yeah. Actually,
speak up for the.
Yes, and thank you, Denise. How could you explain to practitioners how distress, recovery, and meanings work parallel with each other? There is the expectation that the distress and the recovery can work together.
Distress and recovery cannot work together?
Yes.
Huh. I'm not sure I understand the question. Do you?
Probably that she meant she expect, you know, that distress and the recovery is the working together, you know.
Okay, right. That's what I think that's right. So that's actually a great question because that's why meaning is the centerpiece. Since distress is always filtered through, so what about my distress? What does this mean to me? What does it mean to me as a person? What does it mean to me in my life? That will totally shape the recovery journey. So if, for example, my suffering signals to me a spiritual deficit or a spiritual concern or a void in my life, I might go about recovery in a spiritual path. I've talked to 3 or 4 GBV survivors who did, I don't know if you've ever heard of there's a walk on northern Spain that you walk from sort of France to the edge of yes. And I've talked to 4 people who did that walk because they perceived their suffering and their experience from a spiritual lens. Some people we've discovered in our trauma recovery research experience it as absolute social violation. They identify almost 100% as a survivor or even a victim. And their recovery journey is about, you need to take care of me. You need to give me support. You need to, it's this, right? So it's all about meaning, in my opinion. And that meaning is malleable from a psychotherapy point of view, from an intervention point of view. It's not a static thing. You can modify meaning. So people, when they take, the reason why these interviews are so interesting for people is they come away with a kind of a different meaning. And that new meaning is growth producing in some way. And that's what we want. You want people to sort of think deeply about, who am I and what does this all mean? And what do I need related to that? Why am I pursuing that? Or why am I not pursuing that? Why am I not pursuing health? Why have I been suffering for 25 years? Like there's nothing I can do. Oh my God, there is things I can do. That's so cool, right? So I think meaning is the centerpiece there between suffering and healing or recovery. Oh, sorry.
The interview tool that you described that was you call it culturally neutral.
Mhm.
So this is a tool that was developed out of studying the Japanese population,
Sure.
and then
By a Western researcher.
by Western research group. So then how is it being used? Is it being used? Cause I think you said that you're starting to see some patterns between different cultures. So it's being used
Mhm.
kind of across
Yes.
populations.
And the reason I say culturally neutral before you get to your question is culturally neutral, of course, it's not completely culturally neutral because you have to be able to put pen to paper or you have to draw in some way. You have to be able to talk. You have to be able to maybe even write. So it's not completely neutral. Obviously, maybe you need to be literate, although there's easy applications to any of these for a non-literate population. It would be very easy to do. So
Yeah.
it's not completely culturally neutral, but
Well, I'm really interested in how the need to have clinically relevant like outcomes pushes you towards generalization. think.
yes, that's
It pushes
absolutely true.
But then the actual treatment context pushes you back towards
That's
specification,
exactly
because you
it.
need to
Excellent way to explain what it's like in our world, right? So that's the purpose of the theory, actually, because the dark headings are a perhaps universal something that we might see across any population. So everybody experiences distress, and everybody's distress prompts them to do something about it, to recover in some way. And then what we're trying to do is isolate the big bubbles. What would that be? What would that big phenomena that promotes or diminishes the movement? And then within that, actually, it's going to be culturally specific.
Okay, so now I'll get to my question. Sorry. So then when you make these cultural categories, I think that I heard American was a category.
Yeah, it's a character.
So I'm
What is
wondering-
that, right?
Right, so I'm wondering.
Totally.
How is this being used? Does that potential be used within like American
Mhm.
context?
Yes.
Where you're no longer like seeing a person as American versus the rest of the world. or
That's
something
it.
Like that, but like different populations.
Subgroups and populations
Yeah,
in
is it-
America. So behind
it-
you is Dr. Laura Cinco. I'm so happy she's here. She's one of my former students, colleague, and one of my good friends, and she is actually doing just that. So she's working with gender minorities, and I've been working with immigrants forever. We have several groups who are going to work with immigrants. Right now, we're going to do a big Muslim population, for example, Muslim study, but we know within Muslim communities, there's 6 or 7 different ways to be a Muslim person.
Great, yeah.
So the trick, actually, based on what you're saying, though, is how do you discern what's across groups? Like, what's gender-based violence specific across any group? And what's specific to that Turkish population that we talked to? And what's specific to the Japanese? What's specific to? That is a massive enterprise. Thankfully, we have quantitative and qualitative data. So we actually are starting to explore that now. So we have several big papers where we're actually comparing across groups qualitatively. It's not really being done. It's exciting, super hard, takes about a year. But really, what's the meaning for this group? What's the meaning for this group? What's the meaning for this group? Is any of those shared? No, actually, most of them are not. But within that meaning, what we see as meaning is important. Right? But the specifics of that meaning is going to be to me or to you or to you. Great question.
I have two questions that are maybe interrelated and are kind of about being a researcher of this kind of topic. One is, how would someone without like medical or counseling training approach doing, say, qualitative research on these kind of topics?
Good question.
And also, as a researcher, how do you respond to or grapple with kind of being witness to other people's distress and trauma so much?
Exactly. Those are so good questions. And it's the heart of our work, really. The first question, how people who are maybe not clinically trained, how do they? What we're looking for really is maturity and sensitivity and self-development in a sense, because the interview is so easy to do. The analysis of that's another thing, but you know, the doing of the interview. So I know Sachiko, for example, one of your team members is not so, she's got a couple psychiatrists or something, but she's got another team member who's maybe part of the general community. I know Laura does as well. I have most of my people work that, but there's so many people who cannot do it because of the second piece. They can't tolerate the pain. And it is hard. It is extremely challenging to witness people's distress. So one of our training is really more about self-containment and understanding what you're experiencing and being with the person while they're experiencing that, and that this is not your experience, it's theirs. But your witnessing and your sensitivity is healing for them. So the more you are self-contained and engaged, the more they can express what they need to say. Right? So it's better interview data, first of all, but it's also better for the participant. But it's hard. So our research teams always have a self-care component. And Laura and I just wrote an article where we're proposing self-care research, self-care components in standard practice, because it's not written about and it's huge. So thank you for that.
Thank you. Thank you. So there is another question from online participants. That's a fun question. I like it. But hello, I'm a environmental science
Oh,
student
fun.
at EMU.
Got it?
As a total layman, but I really enjoy your talk. Have you noticed an impact from your research in your field? I'm invested to hear you have made a difference.
Oh, God, do we want to make a difference? Well, one difference we've made is every person who's taken our interviews says they love it. Not every person. I think there's 3 who hated it. I had one person who threw it at me. So I'm not doing this. Right? You know who she is. That was intense. But anyway, most people love it. So one of the impacts we are definitely having is in the qualitative piece. The people are walking away with some sort of sense of change or motivation, maybe I want to say motivation or inspiration somehow, or hope. So that's definitely something that we're seeing, but it's quiet. It's not documented. We've written about it. It's not changing the face of medicine in any way. So unfortunately, I don't know if we're changing society. That's what we want to do. We want to change society. Dr. Kita will be talking about the care guidebook, I imagine next year. We want to actually change practice. We want to create a way where a practitioner can sit down with a person and listen to their story first before they ask the checklist. Wouldn't that be so cool? If you could just say what it's like for you first, before they give you a name and a diagnosis and a treatment plan. So that's what we want. Before I retire, I would love to see. So we're waiting for the psychiatrist. who's gonna let us use their clinic. Or some of the shelters, the GBV shelters, the IPV shelters, domestic violence shelters are interested, but they, you know, they have the assessment forms they have to fill out, you know, so.
So follow up on that, so what you're doing right now is in the context of research, it's not. It's
Well,
not
we're flipping to
widespread or-
practice now.
Okay,
So we really needed to make sure that we could do it internationally, that we could do it with pockets of populations, that the measurements are valid, that our approach really is culturally sensitive and trauma informed. We're sure of that now. We've been around the world affirming that. So now we're ready to say, okay, but this actually is helpful also.
so you have to go to like the American College of Psychiatrists or something?
Yeah.
Like conferences and be like. "Use
That's
our
it.
methods."
Exactly. Exactly. Use our methods. And you know, and they're instantly defensive. No, our methods are better. Because they're structured clinical interviews that are given by psychiatrists. And I'm like, you know what? No. I'm sure that they're not the same. I'm positive.
Can I just share?
Yes, dear.
I think you're being modest. I think another impact of the work that you've been doing is really to move the needle in research about how do we gather data in a way that is not exploitive, that is therapeutic in some sense. And I think like people who've read these sorts of articles, these methods, I think there's been ripple effects in the way we gather data, which therefore has an impact. So I wanted to name that.
Oh, thank you. Thank you very much. And I think that's why our research team is so robust. So we've got 35 or 40 people in our research team all over the world, and they're loving the work because it's good, it's helpful, and they don't feel ethically challenged, you know, because it feels like that. When you do research, it's scary. You don't want to hurt anybody, but they do. Like I talked to this one woman, it's a little anecdotal story, but she wanted to study the transition experience from male to female. So she wanted to study the transition experience, and she wanted to use just the body map. And she wanted to talk about the experience of being violated, sexually assaulted during that experience. And she only wanted to focus on the rape. And I'm like, no, I want no part of that. That's outrageous. Are you really going to go in and trigger that extremely vulnerable person, and then another one, and then another one, and then another one? And that's the face of our research industry right now. So that's what you're referring to. You know, we can do this better.
Hi, thank you so much. This was super interesting. I feel like I've learned a lifetime's worth of knowledge in just the past hour. And this is kind of a basic question, but I just wanted to know like what for your initial study with the like questionnaire, like or with the 120.
Yeah, 120. Yeah.
What was the recruiting process like for that?
Oh, that's
Because,
great.
yeah,
Great question.
I know there's a lot of, and I don't know the specific differences between like American and Japanese society on this, but I just know in general, there's a lot of like shame coming forward with this
Yep.
diagnosis. And there are a lot of people who
Totally.
won't do it at all because they think they have these symptoms, but they don't
That's it.
want anyone to know.
Mhm. That's exactly right. That's a really good question. First, there's two parts to it. One is this actually was about how a person goes from being distressed to getting help. So what I know is I could easily recruit from a clinic, but isn't that person already pursuing help? Right? And I want to hear from the ones who don't. I want to hear why they don't. I want to hear what's going on for them that they can't even go to their doctor's office, which was in Japanese, by the way, down the street from their house, and they couldn't go. So that was extremely challenging. So we had a multi-pronged, so I was putting the interviews in grocery stores. I was putting them in the libraries, in the Saturday school. I would do talks at all those places. People were super interested, and then they would slyly take the little thing and kind of put it in a purse. So we got a really robust sample of about 250 people pretty quickly. The second thing is, in the book, it was, at that time, it wasn't online survey, so it was a book, and it was a really pretty book, and we wrote lots of nice stuff to community. And it was nice. There was a nice cover letter, and it was kind of pretty, and we had a good, nice logo. Anyway, in the back, people wrote long stories. And also sent the ticket, please do not call me. So we heard these, medical abuse, basically, in the hands of the medicine society. A lot of people were going back to Japan to get their health care. I would say probably of those stories, at least a third, maybe half said, I can't. This healthcare system is too cruel. I can't. They're giving me names, they're giving me pills. They don't want to take pills. Japanese don't want to take pills for anything. Even when they're pregnant, they don't want to take the vitamins, right? So they didn't want to take pills. So it was a fascinating, and we're still doing that now because we're asking for the IPV survivors or the sexual assault survivors, what's happening for you with regards to coming forward for your shame or your same thing, right? So how do you recruit them? So that study, we might recruit through the healthcare system in the broadest sense, or emergency rooms is a really good place because they're not actually seeking help, psychological help. They're seeking sort of physical health care in some way, for sleep or pain. And at least 2/3 of the people or 3/4 say, I've never told anybody. At least. It depends on the population in the country, but in Japan and Greece and Turkey, it's probably much higher than that. It's probably 75–80%. In America, maybe it's a little bit lower, but it's still very high. They don't tell. They still don't tell, even with the Me Too movement.
So that it's almost time. Still, the 1 or 2 questions can be accepted. But anyone else?
I have a quick question. Thank you very much for the great work. And I realize I'm answering the medical question like hopeless for I'm not going to commit suicide. So
I know, exactly. That's what I'm saying.
Japanese. So I don't
Exactly.
want to, but anyway, I'm going to ask the one question from different angle
Mhm.
because living and working and taking the American health questions. Japanese language has a lot of
Onomatopoeia. Got it. That's right. Right. It's just
I can't find the English.
you can't find it. No,
And
I
you're
know.
saying about the translation. So
Yeah.
My question is there any attempt to create a handbook of like a dictionaries?
We did. I
Yeah.
don't know what the Mazda people did. We actually labored for months creating exactly that, to give voice to the Japanese experience and also to explain the meaning of that question or why did they do it that way. Don't know what Mazda did with that. We actually made a fairly thick kind of a tome actually for that exact thing. And what we did in the 120 items, the reason it was 120 is because irritation and annoyance and anger are very different in Japanese language, right? So we were trying to say, okay, we're getting them all. It turns out we didn't need most of them. Most people didn't choose those. So we ended up with about 65 symptoms. Now we've reduced that down to about 40 that we're seeing internationally that we can, but translating those across another culture, you can't do it actually. One of the fun ones was lightheaded.
Yeah, that's
Lightheaded
the
was amazing. So we did this translation thing. We had 7 or 8 countries and we were trying to translate lightheaded and we spent hours on it, literally hours. Well, lightheaded, no, it's spinning of the head. No, that's, well, no, it's dizzy. No, it's, you feel like you're going to faint. No, that's blacking out. And it's like, oh my gosh.
Is there any way to share the kind of handbook with?
I don't know where it is now. I probably
okay.
can't find it because I was at Michigan State and it was in the 90s before the computer. So it would have been typed. So I don't know.
It's a useful resource.
I totally think, I agree.
public.
I agree. And I know Dr. Fetter's office, he's gone now. Oh, Mike. But their office definitely does have some stuff, but I think it's become quite medicalized again. I don't think they were really attending to the daily life jargon that we were.
Okay, I have a problem because I was trying to express in English my symptom and I couldn't, but I didn't know the word.
I know. I
And
believe you.
so actually I went to see a physical therapist and I kind of.
You mimic?
Yeah.
Mimic it. That's the best way to
She
translate.
said, oh, that's lightheaded. Oh, okay.
That's great. Well, thank you, everybody, for listening.
Yeah.